wellness revolution starts now.
Hello, I'm Dr. Steve Hotze, and welcome to today's program. I have a very wonderful friend of mine and a very interesting, innovative thought leader in innovative medicine and in the treatment of cancers, Dr. Nathan Goodyear. Dr. Nathan Goodyear hails from Louisiana, I believe is where you were born, wasn't it?
Well, I actually was born in Phoenix, Arizona, Steve.
You were born in Phoenix, but you ended up going to Louisiana Tech, played football there, went to LSU Medical School, went off to the University of Tennessee to do your residency program where you were a chief resident there. Yep. And over time, after you started your obstetrics gynecology practice, you went into pelvic floor surgery. And then you became interested in oncology, innovative methods of treating cancer more naturally than using normal oncology, which would be radiation therapy, surgery, and chemotherapy. And we're going to talk about that as we go through this program. He's known, he's run several clinics in the Phoenix area for several decades, and Dr. Goodyear is now affiliated with the Williams Cancer Institute here in the United States, and which does a lot of their work down in Cabo San Lucas, down in Mexico, where Dr. Goodyear and his wife currently reside. He's renowned in the natural approaches to cancer treatment around the world. He's just published a new book, Breaking the Cancer Code, 7 next-generation integrative oncology therapies. And we're going to talk about that as we get into the program. So I'm pleased to have you on the program, Dr. Goodyear, and I know our audience is going to be intrigued by your insights. So let me ask you some questions first before we hit on the cancer therapy. Tell us about, in your treatment of in obstetrics and gynecology, did you have any experience with treating with natural bioidentical hormones, estrogen like Biest and progesterone, DHEA, cortisol, and other pregnenolone? Did you use that at all in your practice, and what was your experience?
Yeah, first of all, Stephen, as I told you before we hopped on the camera, I consider you a friend and a figure to follow in how you've led, I think, the medical community. So thank you for the work that you've done and that you continue to do. You're welcome. When we go through our life, we basically write a book. Of course, we're not writing it alone. We're writing it for you and I with the ultimate author, God.
Right.
And for me, when I started, I always had a natural tilt. When I played college football, I was center. That's the guy that snaps the ball to the quarterback. I had to know what every person on the field was doing, not just the other 4 offensive linemen. And so for me, then shortly thereafter, and so we weren't small. Shortly thereafter, within 5 years, 2 of the offensive linemen I played with had massive cardiovascular events and passed away.
Wow!
And I knew with a budging fledgling family that I wanted to be around. So I sought out means to live healthier as I was going through my medical training. And the Lord put together in my life somebody at that point, a compounding pharmacist, those great corruptors of thought. Actually, that's a joke. And his name is Joe Now, and he still resides in East Tennessee. But he was asking me as I went through my residency and training, where's the double-blinded randomized placebo-controlled trials that tell you that pharmaceutical hormone therapy is the best, or that birth control pill is the best, and et cetera. So that was something that I think was really ingrained in me from the very beginning. So when I got out of my residency, it was mostly pelvic floor training that I went to there for. So I did mostly pelvic floor surgery, a little bit of obstetrics just early on, but hormones were something I did right out of the gate. I mean, Biest, never use Triest, of course, because I
Right.
don't like estrone at all. Biest, estriol, E3, progesterone, cortisol, and thyroid was always a part of this. But what was more interesting to me was, as I said, not just one hormone, but it's looking at that offensive lineman kind of concept where they're all working together. Okay. Homeostasis. And so for me, I look at hormones that same way. If you have five offensive linemen and they don't work in unison, then you have a quarterback that's about to get his head taken off. But if you have hormones that are working in unison, or offensive line that's working in unison, and hormones being the metaphor there, then what you have is as some people have described, a symphony, beautiful music. But yet one gets off, it basically ripples through the body. So I have long history there. And in fact, that's where I started in 2006. That's where I started treating men, because I figure, hey, women, I can help them. And they said, well, you help me. How can
you help my husband?
Husband. And I thought, well, how hard can men be? Well, some of my most hormonal patients have actually been men. So,
Right.
but they present different challenges. And that's where I wrote two of my older books, because I thought, you know what? I'm not going to dive into that concept of men health, even though I was partly trained in that, because we did a lot of just general practice in our first couple of years. But it was, let me just dive into the science and look at testosterone in men, and let me look at the hormones in men. And only then, once I have a handle of that, will I then proceed to that treatment strategy. And that's why I wrote those books. But yeah, long history.
What were the names of the first two books you wrote?
Yeah, first one was Man Boob Nation. That title actually comes from my youngest daughter, who's now 20. We were on vacation and guy walked by in a yellow Speedo and man boobs. And she said, Dad, look, boobs. And I said, oh, dear, there's the title of my book. So thank you to Sarah for that title. And then Testosterone Revolution, Total Transformation. So kind of a update to that first book. So those were the books. And but hormones have always been a part of it. Then I got into hormone metabolites, which I think are just something that nobody ever really talks about, that hormone metabolites are the breakdown products of these parent hormones. And there's crossover communication. It would be easy to say, as I like to say, this is a little crude, but I think it makes people laugh. Hormones are much more than just an estrogen-fueled hot flash or a testosterone-fueled erection. They have massive implications throughout the body, not just as standalone, but in combination, in cross-communication, and in the metabolites. And now in cancer, it plays equally a significant role.
Well, tell me about tubal ligations. We find that of all the podcasts I do, the one that's looked at the most and is the one about tubal ligations and tubal ligation syndrome. Tubal ligation, folks, is when doctors go in and tie a cord around the tubes that lead from the ovaries to the uterus, and that's where the egg is transported and getting ready to be impregnated during sexual intercourse. And women don't want to get pregnant, or their husbands don't want them to get pregnant anymore, and they'll do a tubal ligation, which can lead to a host of health problems. Describe what your experience is with tubal ligations and what you did to treat the syndrome that occurred after tubal ligations.
Well, I mean, let's first talk about, what I believe drives tubal ligation syndrome. It's when you go in there, there's a variety of different techniques that would be employed to actually stop fertility at that point. Basically, you're closing the fallopian tube. The fallopian tube is what connects the ovary to the uterus. So basically, when, as Dr. Hotze correctly described, when the egg is released from the ovary, then it travels through the fallopian tube, where somewhere in that process it meets with the sperm and then migrates then into the uterus where it implants. But if you block the fallopian tube, then obviously those two never meet. Now, when the techniques employed, at least at my training time, were you could tie them off, you could basically ablate them, destroy them, you could cut them. And so in most of those techniques, what you would do is you would really compromise some of the blood supply going to the fallopian tube. But some of the blood supply going to the fallopian tube, guess what?
Goes to the ovary.
Goes to the ovary. And so when you compromise blood flow to an organ, you compromise function. For me, I had to have one of my adrenal glands removed for a pheochromocytoma. That's what led to my transition into the cancer world. But I remember the surgeon telling me when we were meeting, he said, "Oh, you won't miss that adrenal gland. You've got another." Yeah, I miss it. I can tell. Same way, if you remove the uterus and leave the ovaries, those women would always proceed into menopause much quicker. Why?
Sure.
Because you compromise the blood supply. So here what you're doing is you're compromising the blood supply to the ovaries. You're then compromising ovarian hormone production, okay? And understand that ovarian hormone production in women, in that aspect, you're going to decrease both estrogen and progesterone. You can precipitate early menopause, early perimenopause, where hormones get out of balance. And when things get out of balance in the body, that's where inflammation sets up. That's where disease can generate. But the key here is it really sets the stage for early menopause, that really then sets the stage for immune imbalance, that then sets the stage for accelerated cellular senescence. And that is what accelerates aging, and that's what accelerates disease. So for me, I think that's the timeline of what happens here. For me, the concept of tubal ligation syndrome, when I was in my training, Stephen, was not something I ever heard. It was actually only after I really got out of the arena of obstetrics, where I was doing the tubal ligations, which was very early, about 2008, that started to really become, I think, something that I would hear from time to time. So I never really had a means to manage that. But if I did manage that now, it would be basically retrofitting what I just described there. And it's targeting cellular senescence, targeting chronic inflammation, looking at the hormones, the hormone metabolites early, and modifying them so as to prevent that cascade of events.
Right. And what we find in the treatment, of course, is what you would do now. We use Biest, and we use progesterone primarily, and we also add pregnenolone and a little DHEA, but that can be a godsend for these women because you're restoring the hormonal balance. Remember, ladies and gentlemen, in a natural, normal menstrual cycle, it's approximately 28 days. After a woman has her menstrual period, which may last 3 to 5 days if her hormones are balanced, she begins to make estrogen hormones. The estrogen hormones promote the proliferation of the inner lining of the uterus, gets it all beefed up and ready to receive a fertilized egg. When the egg is given off midway through the cycle, usually on the average day 14 or 15, the egg, of course, travels down the fallopian tube. And then in the area from which the egg is derived, a corpus luteum is formed, which produces progesterone, which promotes gestation, promotes pregnancy. It matures the inner lining of the womb. And so and then if there's no pregnancy, then at the end of 28 days, the hormones drop, and then you slough the inner lining of the womb, and that's the cycle of life in a woman's menstrual cycle life. As women mature, the ovaries age, and oftentimes their progesterone levels begin to drop, and the estrogen levels, while it may drop as well, it doesn't drop as fast, and they get estrogen dominance. So they get proliferation of the inner lining of the womb. If they don't make an egg that month, they don't have any progesterone, and their periods become heavier. Instead of 3 to 5 days, you may be 5 to 7, 7 to 9. They get breakthrough bleeding, they get cramping, they get clotting. And then they get all the premenstrual symptoms: mood swings, fluid retention, weight gain, migraines, headaches, breast tenderness, fibrocystic disease. And these can all, and then that ultimately leads going to an OB-GYN, and he says, we can solve this problem real quick. We'll just cut out your uterus. You won't have any more problems. But it hasn't addressed the underlying hormonal problem that caused the hormonal imbalance that caused the problem to begin with. So ladies out there, if you're having problems with premenstrual symptoms and heavier periods, don't let them take a knife to you. Progesterone can be a godsend. We've saved a host of women from hysterectomies. As a matter of fact, if a woman's had a hysterectomy, of course, that's going to adversely, especially if she had bilateral salpingo-oophorectomy and her ovaries removed at the same time, she is going to be thrown directly into menopause, and routinely they put you on Premarin, which is horse estrogen, which causes a host of health problems because they don't give progesterone. So I really oftentimes when I have a woman that's come in and she has had a hysterectomy, I delight that I'm going to really be able to help her because I know what caused the problem to begin with was lack of progesterone. And you give them progesterone and it turns the lights back on. It's wonderful. It's, helps with anxiety, thinking. It helps with mood swings. It helps with sleep, helps you with weight loss, helps you with romantic moods and inclinations. It's a godsend. As a matter of fact, I built this practice, Dr. Goodyear, on two preparations primarily, natural desiccated thyroid and progesterone. And progesterone has just been a godsend. So I wanted to have you bring this whole concept up about tubal ligation syndrome and how that can lead to the hormonal imbalances that cause you a host of health problems that causes you early aging, which you don't want.
Well, look at what you mentioned there. You connected it to different areas because what we're talking about here is communication. Communication is key to a successful marriage, successful family, successful business, and you know that better than almost anybody. And so when communication breaks down, guess what? Function breaks down, whether that be in the business, the family, or the marriage. And in the body, it's no different. Hormones are a language. It's a means of communication. Why? When hormones are dysfunctional, guess what? The uterus doesn't function correctly. The ovaries don't function correctly. But that's not just confined to the sexual organs. You mentioned mood disruption, right? So the hormones disrupt neurotransmitters. Right. We know that hormones will disrupt the immune system. And of course, for me and at the Williams Cancer Institute, that's something that Dr. Williams and I are intimately looking at, is this immune dysfunction that really permeates from a really young age. And hormones are a means to disrupt that, and vice versa. Inflammation can disrupt hormones because you said metabolism. That estrogen dominance and hypothyroidism, right, as you mentioned, desiccated thyroid, that's going to elevate weight. Now, when that weight elevates, that adiposity, the fat, is not just inert. It's just not for looks. It's hormonally active. It's inflammatory active. So what you start to see is now a cascade of events that will permeate this person down accelerated aging. And of course, disease is associated with that. And you're right. It can all begin with hormones and can all be precipitated by hysterectomy with removal, the bilateral salpingo-oophorectomy of ovaries and tubes. But we believe that those were given to women for a reason. So let's keep them there as long as we could. I always say this, Stephen, if we flip this to men and men went into their urologist and women, they go into the gynecologist, they go, well, you're 42, you're done having children, right? Okay. You got some hormonal issues. Let's go ahead and remove that uterus. Let's go ahead and remove those tubes and those ovaries. The way the standard of care has stepped in, the way culture has accepted that, women go, okay, great. That's fantastic. Flip the coin. What if men went into the urologist at 42? The urologist said, hey, you're kind of done using that, aren't you? Yeah, not really. Well, we're going to go ahead and cut those off. There would be a complete change, I think, in perspective because you'd have a lot of doctors with broken jaws. So, I think organs were created for a reason. Now, there's sometimes reasons to remove those because of major issues, of course. But at the same time, hysterectomy shouldn't be the number one surgical technique or procedure in women.
And I've read there's somewhere between 600,000 and 1 million unnecessary hysterectomies performed every year. I had a gynecologist tell me one time when I was in training, he said, I go from room to room prospecting for potential hysterectomies.
Oh, wow. That's honest, but that's frightening.
And it's probably more. It was true in him, and it's probably very true in a lot of gynecologists. The first half of their career is delivering babies. The last half of the career is hysterectomies. Basically,
they're looking for CPT codes.
That's right.
They're looking for codes to get reimbursement. I mean, that's really what it is.
Well, let's talk about cancer right now. Your story is that you had pheochromocytoma, which is a tumor of the adrenal gland, and you had that removed. And then how did that lead you into your studies of integrative and more natural approaches to treatment of cancer?
Well, it really began with hormones, Dr. Hotze. It began with bias. It began with the research of the three predominant parent estrogen compounds: estrone, estradiol, estriol. That's interestingly enough, estradiol is the most potent estrogen, yet it's E2, whereas estrone is E1. It's because it was first described. Estriol is the estrogen that dominates during pregnancy, and then progesterone. So as I was working through those with women in the wellness kind of movement that I started in, that I was involved in 2006, the question would always come up, okay, what's the risk of my use of Biest or progesterone or pregnenolone or thyroid and cancer? I have a history of breast cancer. What's my risk? So that was already there, that interest, that connectivity. And that's really what fueled my interest in hormone metabolites, because it's like, okay, if we just look at estradiol, that's just one hormone. That is oversimplifying a process in breast cancer in women. And we now know there's many different types of estrogen receptors, which are basically what's called genomic signaling, but there's also off genomic signaling, what's called non-genomic signaling with hormones. So this concept of hormones is, as it relates to cancer, is so different and so complex, but we recognize the complexity and understand it and say, okay, now move forward. It doesn't mean we can't understand it. But so as I was already in that movement, hormones were already a part of it. Testosterone and prostate cancer, it was just there. And so as I migrated through my practice into the full wellness industry out of gynecology, half of my practice either had a history of cancer, had active cancer, was wanting augmentation with their conventional oncologist. So it was already there. And then the way I look at it, God just touched me on the shoulder and said, I want you to actually carry that to the next level. That's when I was diagnosed with the pheochromocytoma, and which debate about whether mine was malignant or benign. All I know is my blood pressure was 300 over 130, and I was a diabetic, though I was 178 pounds. So it was one that if I didn't get it surgically removed, I was going to stroke, because blood pressure wasn't pressure medicines weren't controlling it. And so I had to get that surgically removed. So for me at that point, I knew I was supposed to transition to cancer all the time. So I moved out to Arizona, where I'm now licensed as an MD and an MD homeopath. So I have the freedom and flexibility to practice a more holistic approach. I believe that integration with God's creation is the better way to approach medicine. Medicine is a reflection, I think, of the greatest physician, right, Jesus. And I think emulating that more provides more opportunity to heal. It doesn't mean we can't use surgery. It doesn't mean we need to avoid radiation. So if somebody has a brain met and swelling, we got to do something about that. We cannot let that stay and not live another day. We can live another day to now work to eradicate that. But at the same time, we have to recognize that radiation can actually upregulate the metastatic risk with amphoregulin, and many other mechanisms. So they're one and the same. And so I still work through hormones and hormone metabolites with some of our cancer patients. I still work through that in my mind, because the biggest connection here is probably the hormones to the immune system connection.
Right.
And so I look at, what I worry about, let's just open a can of worms here, Stephen, is, post-COVID, the vaccination. We know that the spike proteins had a preferential, connectivity to the female genital organs.
Right.
Okay. So, wow, what's that going to do to chronic inflammation? What's that going to do
to fertility?
Fertility, but then female-associated cancers.
Mm-hmm.
I don't think we have to sit there and wait on a 20-year double-blinded randomized placebo-controlled trial, some new nurse health study, to basically put the puzzles together and show the connection. And, that's critical thinking. And so I think we know where we're going. And unfortunately, we're already seeing a future, I think, lay out.
Right. There's been a significant increase not only in female and ovarian cancer and those problems, but tubal cancers all the way around the board from the injection, as well as dramatic increase in myocarditis. Peter McCullough, who's a friend of ours, yours and mine, is a cardiovascular or cardiologist. He's been, and I visited with him, had him on the program, and I said, let me just ask you, how many cases in your career prior to 2021, prior to the vaccine, how many cases of myocarditis? Now, this is inflammation of the heart muscle. How many cases had you seen in your career, which had already been 30 or 35 years? You know how many he told me he had seen?
Probably none.
2 in 30 years. You know how many he's seen since 2021? Well over 1,000. He sees 5 or 6 or 7 every week.
Yeah.
So we know, and that all started. I mean, it's not rocket science. If a robber comes into your house and he has a gun, you don't have to have a double-blind study to see if he's there to rob you. He's obviously there to rob you. Same thing if you've got before the COVID injection, if there was basically little or no myocarditis, and now all the people, and I said, do you see this? Who do you see? And he said, almost to the person that has myocarditis, they've taken the injection. So
and what's itis? Itis is inflammation of whatever's connected to here, cardiomyocytes. So it's the inflammation of the heart and surrounding tissues. So inflammation is directly connected to hormones, right? And, I right there in the background, Dr. Hotze's wellness revolution. Now, that word wellness is 2 words, wellness. It literally could be translated, if you look at a root origin word analysis of it, into disease, is the lack of wellness. And wellness means to make whole. So really, when you're talking about wellness, you're talking about the lack of disease. When you're talking about disease, you're talking about the lack of wellness. And so where we're existing is somewhere on that continuum. And the environment that we live in, both outside and inside, it's one that is promoting an environment that
promotes disease
and it drops hormones, and it promotes inflammation. Now, I think it's important to understand that itis or inflammation, stimulating the immune system, which promotes inflammation. You sprain an ankle, you see the swelling of it right there. That's good. You get a paper cut, you see the inflammation, prevents secondary infection. That's good. But inflammation doesn't always equate to good. So if disease exists, inflammation can be turned on the body. Inflammation can be used against the immune system. So the immune system can be used against the immune system, such as in cancer. So just saying we have inflammation doesn't equate to being bad, and just saying stimulation of the immune system doesn't mean good. So I think it's very important to understand that, and that gets back to communication, hormones and cytokines. These are the immune signals. Hormones are really affecting them as well. And so you can't really disconnect this relationship that exists.
Well, and let's go a little bit farther on that about the petrochemicals and the chemicals in the environment that serve as estrogenic types. They're called xenoestrogens because they have the similar effects on the cells of the body as does estrogen hormones. So we know that in males over the last 50 years, there's a dramatic decrease in testosterone levels and in sperm counts. And that is related to the petrochemicals in the environment that are in all the food that we breathe in the air, that are in the pesticides everywhere. The outgassing from paint, from new carpeting, from new clothes, going to the cleaners, for crying out loud. They use petrochemicals to do your dry cleaning. So all these have adverse effect on the hormones in the body, and they can adversely affect not only males and adversely affect their production of or the function of their testicles, but also can adversely affect females. And there are production of natural estrogens. And I'm going to go back to something you mentioned earlier, and we were talking about estrogen dominance. Estrogen dominance creates in a woman, this is when as she's going through her menstrual life, she gets into her 30s, early 40s, we begin to get a decline in progesterone, and we have anovulatory cycles where you don't make, you're not making an egg, you're not making progesterone to balance out the estrogen, so you get estrogen becoming the dominating hormone, and that causes the liver to produce thyroid-binding globulins, which bind up thyroid hormones. So you may have it in your blood. You go get a test from a doctor. Everything's fine, he says. It's within the normal range. Well, the normal range, 95% of the people always fall within this wide range of normal, which is as tall as the Empire State Building, wide as the Grand Canyon. So, but what happens is the thyroid-binding globulin binds to the thyroid hormones and it can't get into the cells, and thyroid doesn't do anything in the blood. It's got to get in the cells and be converted from the thyroid hormone that has 4 iodine atoms, T4 to T3, the active thyroid hormone. So what we found is if you can balance out the female hormones, particularly with progesterone, if women may not need any estrogen in their early 40s or late 30s, but they need progesterone, this has a positive effect because it cuts down on the thyroid binding globulin and enables them to get thyroid into the cells. And of course, thyroid is like the spark plug to the mitochondria, the power plants of the cell, which causes your body to produce energy, electrical energy, which drives all the biochemical reactions and increases your metabolism. And your metabolism affects everything that Dr. Goodyear's talked about. It affects the brain, it affects your eyesight, it affects your heart, your liver. It affects every organ in your body, in your immune system. All this is affected by your body's metabolism. So when you have low metabolism, what you have is your low voltage.
Yeah.
And people come in and see us and they go, I'm just sick and tired. And I always ask the question, are you sick and tired of being sick and tired? And we can correct that. And we do that using the hormones. Balancing out the thyroid and the female hormones and even the adrenal hormones. People get adrenal fatigue, and we supplement it with a little cortisol, and that helps. But so anyway, I wanted to bring that up. And one other thing I wanted to bring up about obstetrics, we see commonly in women after they've had a child, their baby, they get postpartum blues or postpartum depression, and the doctors throw them on a bunch of SSRI antidepressants, which just make things worse. And the problem is caused by a dramatic decrease in progesterone. A woman's placenta, the placenta which belongs to the baby, makes all the hormones of the pregnancy. And in the last, month or so of the pregnancy, the progesterone levels go through the roof. And I've had women tell me, I have never felt so good as I did my last month of pregnancy. Whatever that hormone was, that's what I want. I felt great. And then when they have the baby and lose the placenta, there's just a dramatic decline. And I don't know if you ever use that, but I often tell women that are pregnant, say, you take your progesterone to the hospital. And I did this with my 5 daughters. And we've had a total of 25 grandkids with my daughters and 2 daughter-in-laws, 25 grandkids. I tell them all, here's progesterone. Take it to the hospital, and that after you have that baby, you take that progesterone. Don't tell the doctor, just take it. None of our kids have ever had any postpartum blues or postpartum depression. So I know it works. And that's a test of 1. Well, that's a test of 7. And we've used this on tons of other women. You want to comment on that?
Well, yeah, I'd like to go back to the xenoestrogens too, but I think that connects in with that conversation there, because when you talk about xenoestrogens, these are chemicals that are estrogenic. They're not estrogens per se.
Right.
They elicit a signal, whether that be through the receptor, the estrogen receptors, here primarily 2 estrogen receptor alpha and beta. There are other variants of that, but also that's genomic, but also non-genomic. So it actually, when you talked about the connections of hormones to events, you're talking about communication. You're talking about the signaling effect. So when you talked about thyroid binding globulin from estrogen dominance, it's the estrogen imbalance where the estrogen is high, progesterone is low, that is signaling the production of thyroid binding globulin, and this is in turn driving a hypothyroid state. Xenoestrogens are very interesting. Let's talk about just one. I think that's very prominent. Everybody should know about, and probably everybody's heard about glyphosate. Glyphosate is, a chemical that is used in the, industrial agriculture industry, and in so doing, this glyphosate has been exposed to us. But what's really interesting to this, I want to set a connectivity here. Glyphosate weakens the soil. It actually takes bacteria out of the soil, bifidobacterium. It actually blocks the ability of plants to absorb the nutrients from the soil. You may go, what the heck does this got to do with hormones? Let me connect it. So the animals, the cows, the goats, the pigs, and whatever type, they eat that produce. And then from that standpoint, that lack of nutrition gets transferred. So that lack of nutrition compromites mitochondrial function. It promotes oxidative stress. It promotes immune dysfunction. And we eat all of that. So then we as humans eat the plants that are depleted, that are nutrient dense. And we also add ultra-processed and processed foods to it. But we eat that nutrient depleted food. We eat that pro-inflammatory food, immunomodulated food, and food that's full of glyphosate, let alone what we breathe or what we come in contact with our skin. So glyphosate then depletes our gut microbiome of bifidobacterium and other bacteria, which in turn upregulates inflammation production. And we know that this connectivity leads to an increase in disease, a shortening of longevity. It's that inflammation that disrupts the immune system, that disrupts the hormone system, and starts to create more hormonally associated cancers. It slows the metabolism, which elevates hormonal obesity-related cancers. So the connectivity to the xenoestrogens, you're correct. It can bind to estrogens. It can also work in estrogen signaling outside of those receptors. Mm-hmm. But the impact of those chemicals, which, by the way, glyphosate it functions like an antibiotic. That's why it kills bacteria in the soil and does so in our gut microbiome. But the connection there of those xenoestrogens ripples through our soil, through our produce, through the animals that we eat and some of the items that we drink. But then it ripples through our gut microbiome, through our immune system, through our hormones, and all of this connects to the inability to maintain wellness. And it promotes disease. But it's one chemical that our government allowed in that has basically propagated every aspect of our lives now for the last 50 years or so.
There was a big case about, I can't remember if it was lymphoma or what, but a suit against the company that manufactured glyphosate. What is that company? It's the big company. Who? Roundup.
Yeah.
That's Roundup is what it's called, glyphosate.
I forget the name of the company.
Well, it's the big one that controls doing all the GMOs and.
They have a subsidiary company that was doing all of those products, and I forget which one it was.
But it's amazing that they have continued to manufacture the product even after they lost this massive lawsuit, and it was a huge settlement that came about from that. Hopefully, Robert Kennedy can do something about getting this ban, but it's a multi-$100 billion industry. And money talks.
And I think that's where RFK, shout out to Secretary of Health and Human Services. I hope he listens to this. We have to go back to regenerative farming. That's become a passion of mine. Because I think that we as physicians, we prescribe things, right? Hormones and medications if need be, bias, progesterone, pregnenolone. I love all of those. But at the same time, why don't we prescribe? Why don't we collaborate with farmers? Because, farmers basically seed wellness or they seed disease. Mm-hmm. That's really what they do. And what we're seeing today is not a revolution of wellness. It's a revolution of disease. Now, we need a revolution of wellness. Okay, that's what we need. We need a change. But it can't occur in just saying, take color dyes out. That's a great place to start. But Secretary RFK, we need to empower local regenerative farmers to collaborate with doctors and collaborate with patients to really fuel a local healing environment, because that's going to ripple through the hormones. That's going to ripple through the inflammation. That's going to ripple through the gut. And so I think if we try to parcel and piecemeal things and say, let's do this, let's do this, let's do this, I think all of that is admirable. But I think what we really got to do is step back and go, let's connect these dots and let's work on them now. Let's work on them now. And so I know you have a broad reach, and I hope he sees this, but because I think we need to move in that direction.
Well, excuse me, I've visited with him before, and hope to have an opportunity to do that again. I have a close friend that has worked for him politically and has opened up opportunities to do that. And in fact, I wrote a big article in my newsletter about a shout out to Robert Kennedy and how I identify with him and think this is a great movement that he started. Let me go back on the cancer. 3 quick things, and you can make comments on them. Chemotherapy and cancer.
Wow. So we got about 3 hours to discuss that one.
I know. Hit on the high points, the positives, the negatives.
Yeah. So chemotherapy by design actually was born out of war. I've talked about this. I've written about this. By the way, Dr. Williams and I have a new book that'll be out coming that I think it's going to change medicine in general. Because of the concept of how aging and disease are connected. But chemotherapy is born out of Paul Ehrlich's thought that one disease can be treated with one therapy, and that just does not born to exist. That magic bullet doesn't exist. But it was born out of World War II, bombing Little Pearl Harbor, it's called, in Italy. So just look that up, a very interesting concept. That's why when you look at cancer treatment with chemotherapy, it's, go to war, destroy. It's battle. It's a mentality of war. And what that does is that wages war on the immune system. Chemotherapy destroys rapidly dividing cells very well. Guess what? Not every rapidly dividing cell in the body is cancer. The immune system happens to be one of those rapidly dividing cells. And research really shows that chemotherapy can shrink primary tumors. Yay, that's fantastic. But it sets the stage for the metastatic spread. So if we win a short-term victory, yet we lose the war, through metastasis. That's the spread of cancer, which, by the way, that's where research suggests 90% of morbidity and mortality is found. So if we shrink a primary tumor and then spread it, we've led to 90% cause of morbidity and mortality. What have we done? What have we done? Now, chemotherapy can reduce tumor burden, so I think it has a benefit, but we need to really reduce our dependency on it, and we need to find other means because it damages the immune system, which sets that stage for the end.
Okay.
So that's what I think about it.
Okay. So what about radiation? You talked about the benefits if somebody has a massive tumor growing in the brain, you got to shrink it. Give us the positives and the negatives about radiation in general in surgery.
Wow. Yeah, radiation is interesting because it's a paradox within a paradox within a paradox within a paradox, because radiation causes cancer. See, Hiroshima, Nagasaki, Chernobyl. Radiation is used to treat cancer. Radiation causes local recurrence. Radiation causes metastasis, and radiation causes secondary cancers. There was a recent article that just came out, I think, that really highlights my major concerns about radiation because it causes metastasis. They showed it in humans. They showed it in mice. But what happened is they used stereotactic radiation, which is pinpoint radiation, which is good, to narrow the beam and reduce collateral damage to healthy tissue. What they found by the stereotactic radiation of the tumor tissue, it increased the production of amphoregulin. This is a protein that went out and actually created immunosuppression in present distant metastatic sites. So what happened is it shrunk the primary tumor, and guess what? Caused the distant metastatic sites to grow rapidly and spread. So what's interesting, though, is when they then used that on the healthy tissue, that didn't happen. So you would go, well, but we use radiation for treating the tumor. That's exactly right. So it's not that less radiation is better. It's not that narrow beams radiation that's better. It still causes it to spread. So it's the same concept. It has a purpose, it has a role, but we need to step back from our dependency on it because it sets the stage for the metastatic process to grow. And that is an alternative. Yes, it helps us to live another day, but it really doesn't. It actually reduces, I believe, what longevity and overall survival can be achieved. So if you have a pathological fracture, you need to stabilize that with radiation. If you have a brain metastasis with swelling, you need to reduce that. But there's other things we need to do to our dependency on that so as to reduce morbidity and to reduce metastasis. So that's what I think about radiation.
Okay. What about surgery? Pros and cons of cancer surgery?
Yeah, so it's basically the same process. I believe that organs were put there. Definitely sometimes organs need to be removed. I mean, there's sometimes for a hysterectomy, it's pertinent, it's relevant. But when you look at surgery itself, beyond the hormone issue, what we talked about with the hysterectomy, removal of the bilateral single oophorectomy, that creates hormone disruption, which creates immune dysfunction, which then leads to disease, which if you have a woman that has hormones already imbalanced that's being manifested in the uterus, then you already can take to the bank that there's inflammation or immune system disruption, and that is going to set the stage. And through that hysterectomy there, you're also going to accelerate the production and the accumulation of cellular senescence, which is going to accelerate aging, and that's going to also accelerate immune dysfunction. Back up a little bit, though, with surgery, as we're talking about anything related to cancer, it suppresses the immune system. We know that surgery out to 6, maybe even 3 months, the immune system is intimately suppressed from just the process of surgery, not even included the process of general anesthesia or many of the protocols that include Tylenol, which is immunosuppressive. And if you're on immunotherapy, don't take Tylenol. If you're on prescribed morphines, which prolongs the immunosuppression. So the point there is if you have cancer and you undergo surgery and that process is immunosuppressive, what are you doing? What are you doing? So there's a point for surgery, Stephen, but at the same time, we need to move away from our dependency on it. That's why I call surgery, chemotherapy, and radiation the unholy trinity. They are designed to do one thing very well: destroy and buy time. But they're not the answer. They're not the solution.
And they obviously they cause metastatic disease invariably within a year or two.
Surgery spreads it. Surgery causes local recurrence. What's cancer? A tumor has been historically called a wound that does not heal. Well, what does surgery do? Surgery creates a wound. So then if you increase circulating tumor cells with surgery, you suppress the immune system, which will counter those circulating tumor cells, which, by the way, research proves. Then you create a wound. Guess what might happen? Those cells might find their way right back to that tumor. That's why you can see local recurrence many times in that area of the surgery, of the scar, etc.
Let me ask you a question about a specific type of cancer, colon cancer. That's stage 1, basically in the wall. It had metastasized. You do surgery on that. You do a colectomy. In males or females, are hormones contraindicated in a man or woman that has had stage 1 colon cancer that you've removed, that's removed? Or not?
I think if we properly assess those individuals on the front end, we will properly be able to determine whether hormones need to be limited in their use moving forward. I think, honestly, I'm more worried about antibiotics than I am hormones.
Sure.
Research has shown that, giving antibiotics 60 days before any type of chemotherapy or immunotherapy completely removes it. Same thing with the efficacy. The same thing with Tylenol. So I'm more concerned about those than I am hormones. But if we properly assessed their hormone and hormone environment, then I think that would enable us to better answer that question. I also think there's another thing that we could do there too in proper assessment. There's great innovation and advancements in our ability when we biopsy to actually better determine not just the mutations of that the tumor has taken on, but also the immune environment of the tumor and within the tumor microenvironment. So help us to be able to discern between what's called cold and hot tumors. But here I believe then what happens is they get a biopsy. Let's use the better test, but let's not wait for treatment. So we properly assess these individuals ahead of time, and we then properly assess them at the time with a biopsy. But if we're biopsying it, we're putting something into the tumor, whether that be colorectal cancer, breast cancer, prostate cancer. Why not treat that at that moment? Why not treat? Why wait 4 weeks to 12 weeks to now treat?
Right, because even with a biopsy,
treat at the same time. Why not?
Right, because
people go, well, we don't know what it is. Well, what if what we're doing is injecting intratumoral immunotherapies that are activating the immune system against it? What if we're injecting signals like cytokine 15, which reduces metastasis, which could reduce that ability of a biopsy to spread it, though rare, it still exists? Why not do that now from the beginning? And so let's say with breast cancer, it comes back as DCIS, ductal carcinoma in situ. If we biopsy and then treat with ablation and some of these immune signals to activate the immune system against the tumor, done. We're done.
Right.
Woman preserves her breast. Same thing in colorectal cancer. Same thing. We biopsy. It's confined to that area, which is very local, minimally invasive, and we've treated it. We very well could be done.
Right.
And we've prevented all of the morbidities associated with that treatment. But then again, we've done proper assessment on the beginning with hormones to be able to say, okay, we can continue this treatment of these hormones, or we can add this in to help you.
Well, this has been a fascinating discussion. I was hoping we would have time, and this is going to have to go for another podcast, on your book, Breaking the Cancer Code, 7 Next-Gen Integrative Oncology Therapies. And I'd like you to be able to go through those 7 different therapies. I want to talk about ivermectin, minbendazole, or people know the other drug called fenbendazole. These are ones for humans, licensed for humans, one for animal, but they're basically the same drug. Those therapies, hydroxychloroquine, all these in the treatment of cancer. High-dose vitamin C, 60,000 to 100,000 or more milligrams of vitamin C IV suppress cancer. And I know this is one of your specialties and one of your key points, and you're a specialist on high-dose vitamin C. So we ought to bring you back and talk about that. I'm sure you talk about that in your book. I would on the new book that's come out. Is it out yet?
Well, that book's out. That book's been out for about a year. That's my latest book. So that is just talking about where I believe the future of cancer care needs to go through the integrative model. And, when you look at high-dose IV vitamin C, I've taught about that around the world, and I need to write a book specifically on that, because there's so much kind of quasi-true and quasi-untrue statements that people use about that, and how it's clinically useful. By the way, recent study out of Iowa that showed that patients with pancreatic cancer, Gemzar, Abraxane, you add in high-dose IV vitamin C, you double survival. Why is it not being the standard of care? But it's one of the flagships of integrative oncology. Repurposed medications are really fast becoming another flagship of integrative oncology. So just like vitamin C, people would take shortcuts and misuse some of the information to not use it properly. Repurposed medications are the same thing. I just dropped an online course. You can find it at metabolicregen.com, where I'm going deep dives on some of these repurposed medications. Dr. Williams and I at the Williams Cancer Institute, Dr. Williams has really pioneered how these repurposed medications are being used within the immune system. And guess what? If we're working with the immune system, they're affecting hormones. And we're seeing cancer occur at a younger and younger decade of life. And so hormones are going to become a much more real discussion for women and men as we move forward, because we're going to see cancer at a younger state. Mm-hmm. We're going to see disruption in a younger state. So we have to understand the evidence basis use of repurposed medications and the social media platform doctor use of repurposed medications in cancer, which obviously is not necessarily evidence-based. So I think that that's very important, that your platform and others, it's the means to really speak truth through science and actually dispel where science has basically veered off the road.
Right. Well, Dr. Goodyear, this was an outstanding interview, and I know our listening audience is intrigued. If you want to learn more about Dr. Goodyear, you can go to, tell us the best website. You've got 3 different websites. Why don't you give those to us, and we'll list those on the platform when it comes out.
We actually have several. First, WilliamsCancerInstitute.com. That's where we do all things integrative oncology, intratumoral ablation, intratumoral immunotherapy, our regeneration program. etc. Also have pre-scribe.com. That's a personal brand website.
That's pre-scribed, scribed.com.
That's correct. And I also have an offsite of that's just on repurposed medications called off-scriptrx.com. That's just for repurposed medications. I actually talk to different compounding pharmacists, and we just talk about all things repurposed medication. And then the last one is Doc Goodyear, docgoodyear.com. So why all the different platforms? Just because the different platforms have different messages. These are all the different ways. And of course, you can find me on just about every platform, but probably the best right now is Instagram at dr.goodyear. And that's where you can find me best.
dr.goodyear.
And then,
on Instagram.
Yeah, and then my podcast, Prescribed by Dr. Nathan Goodyear, which you can find wherever you download the podcast. And then the Off Script RX podcast, which you can find wherever you download your podcasts.
And they can buy your books through Amazon?
Correct. They can buy the book through Amazon. Just search me there. And they're also on the pre-scribe.com website. We have a store there that'll link out to the Amazon. And then, like I said, just dropping that online course. That course has been in the making for a long time. We're just now finally getting that launched. And so that's going to be something with, it's one module. In that module is 5 courses, the history of repurposed medications, deep dive on ivermectin. I mean, deep dive. Where did it come from? What's the pharmacokinetics? What's the toxicokinetics? How can it be used? What's the research show? What is the research limited by? And how is it best used per the evidence? So that's ivermectin, mebendazole, fenbendazole, hot potato there. And then what's the evidence show about mebendazole versus fenbendazole? Both benzimidazoles. But is there one that's better than the other based on the current available research? And so that's what's going to be available there, and look for more of those to come.
And that's going to be on metabolicregen.com?
That is correct.
Okay.
That's Nation Winners has a production company there that produces these courses. A good friend of mine, a good colleague, and that's where that's being housed. Again, that's been a long time in the making, just finally now getting out.
Well, I need to go through that course, and I intend to do that. Thank you for bringing that to my attention, to the attention of our audience. We've been visiting with Dr. Nathan Goodyear, a thought leader and a pioneer in integrative cancer therapy. He's with the Williams Cancer Institute. Go to his website. Google Dr. Nathan Goodyear, and you'll find out everything you want to know about him. He's an outstanding individual, and I highly recommend, if you're having any problems, if you have cancer, I'd highly recommend you get in touch with him, and you can do that through these websites, particularly Williams Cancer Institute. Thank you, Doc, for being with us. We appreciate it, and thank you for your friendship.
Stephen Hotze, thank you for your friendship, and thank you for what you do, your platform, and I look forward to continuing to cultivate that friendship.
You bet. God bless you now.
At Physicians Preference Pharmacy, we specialize in compounding bioidentical hormones, which means that all of our hormone medications are made right here on site in our compounding labs. The term bioidentical means that the hormones in the products that you're taking, whether that's in a capsule, a tablet, or a cream form, are chemically identical to those which your body produces. So your body responds the same way it would to its own hormones. This is important because hormones work in the body as a lock and key system. Just like your front door, only one shape of a key will fit the way it should to unlock that door. And the same goes for how hormones work within your body. For a medication to be the most effective, with the least number of side effects, we must give your body something that it recognizes as its own. And this is why we choose bioidentical.
Information provided on this program is neither intended nor implied to be a substitute for professional medical advice and is not intended to replace the services of a physician, nor does it constitute a doctor-patient relationship. You should not use information from this radio program to diagnose or treat a health problem or disease without consulting with a qualified healthcare provider. If you have or suspect you have an urgent medical problem, promptly contact a professional healthcare provider or call 911. Dr. Hotze's Wellness Revolution advises advises you to always seek the advice of a physician or other qualified health provider prior to starting any new treatment or with any questions you may have regarding a medical condition. Any application of the recommendations from this program is at the listener's discretion.